work is part of an ongoing process and an ongoing collaboration between the Cerebral Palsy Society, the CP Clinical Network, Starship Research Team, and we are building up the knowledge base around the different stages of cerebral palsy and how they affect families in New Zealand in 2021. Now, it's impossible to talk about the cerebral palsy diagnosis without recognizing the fact that cerebral palsy is an extremely hard thing to talk about from a medical perspective or any perspective. There's a huge continuum of spectrum that incorporate this diagnosis. It's an extremely common condition, but it has an extremely low profile when you are introducing it to families, and it's extremely variable across levels and types, and it's a frequently co-occurring condition, which naturally results in inconsistent language and definitions around the topic. As part of the Starship Foundation grant and the work in this area, we work collaboratively to produce a family survey looking at families' experiences of the diagnosis journey from 2010 onwards. It's important to recognize that families produced both positive and negative experiences. And this is the foundation for a lot of our co-design work and collaborations amongst families and clinicians. And as you can see on the slide, they presented both sides of the spectrum. And it's important to point out that as is the diagnosis spectrum for cerebral palsy is very broad. People reported excellent experiences and people reported problematic experiences. But the fundamental theme that came out of the positive experiences was the idea that the communication was open and honest, and there was enough time for families to absorb the information. And one of the things that came up again and again in the research was the idea that the diagnosis was a collaborative experience. The families were able to communicate and have their questions answered in a respectful and engaging manner. They didn't feel like they were being given a brush off. And what gave most families the greatest sense of empowerment in the diagnosis experience was that they were prepared for the notion of cerebral palsy ahead of the final official word from the pediatrician or the official letter. It was a gentle build up to the approach rather than a single shock event. And that's not to say it was done later. They talked about that it was done in sequential order. It was an expected shock, as they say up there. Recently, there has been a continued shift towards different forms of communication. There's different expectations placed on both clinicians and families when it comes to the medical experience of a diagnosis. Parents and families often come to these events with knowledge based around what they've looked up online or what they've experienced through family groups and connections in social media groups, for example. Iona Novak and her colleagues have demonstrated in multiple studies that families have some level of awareness that either something is wrong or they come across the term cerebral palsy before the initial diagnosis. And it's important to recognize that there is increasing pressure on clinicians to communicate in different styles and different approaches as they relate to the individual families who have different communication preferences. And these are just some of the things that came through both our research and our experience with communities and families. the context of how an individual and a family is given the diagnosis becomes increasingly important, because when you consider something like CP, it's important to see that it is a relay system. You are the first of a medical professional to give them the knowledge around a condition, but you certainly won't be the last. It's very common with cerebral palsy to have multiple conditions and therefore multiple specialists. It's laying the foundation for good experiences if they have that communication with the first person on the relay team. And one of our parents, and I've often remembered this, they talk about the fact that when most people go into the hospital setting, they have an idea around an acute condition. So they have an idea around breaking your arm, putting it in casts, and then it gets better after 6 weeks or so. It's poorly, the idea of chronicity tends to be poorly explained in a medical context for the general population. So their first interaction with chronicity includes a very, very complicated thing in the form of cerebral palsy. So this is just a nice little diagram that I put together of the aspects to consider. And it's what I've reinforced already. Consider the context with which you're giving the diagnosis. Consider the language and expression, because what people consider to be neutral language in a medical context can have quite profound power and expression when it comes to this kind of context. And it's important to note, as one mother talked to me once, that you're already shrinking a monster. The vast majority of parents and families already have some idea that something is wrong or that cerebral palsy may be in play. Therefore, you're illuminating something that is fearful and unknown by giving it a name. Throughout this presentation, I've just selected a few key quotes from our survey work. And I feel like these two really articulate what people are wanting to in two different ways, because families have different preferences, as you can see. The second one talked about their child, and the first one received very gentle information. So there can be that contrast. The diagnosis, the first step of the diagnosis journey is something that families remember, whether it's good or bad. It can be I can often hear stories from 40, 50 years later. Forming a good foundation with the medical professionals is a hugely beneficial thing for the families to move on that next step on the relay. And it doesn't, as I said before, it doesn't necessarily need to be one conversation or one delivery of the news. We can talk about things like surveillance and things like there's a possible risk of this condition, because once again, that's what our families have been asking for again and again, is the idea of knowing something of what's going on in this information desert. And it's usually a good idea to mirror the communication and conversation style of the family that you're engaging with. Many parents have the preferences around knowing everything in the immediate moment of what's going to happen for my child tomorrow and the next day, and some want to know what the child's presentation is going to be like for the next 20, 30, 40 years. And you can usually get a sense of that fairly quickly in how people interact with you. And I'm just going to put a little plug here. Communicating with cerebral palsy diagnosis is really quite daunting, but it can also be a very useful example of the different aspects of medical communication, because you're not going to get one quite like it in the other diagnosis. So it can be useful for practicing these skills around presentation. And I'm sure some of you are thinking that this is going to be like you're presenting the obvious here, but it's the thing that we're aiming for is to get consistent experience so that we don't have that huge spectrum of experiences of really good diagnosis experiences and really bad diagnosis experiences. We want to get some level of consistency around how the language is produced and constructed. And there are aspects towards the diagnosis. So when we talk about families and find our experiences before the diagnosis, there's a lot of emotional build-up to either that clinical experience of the receiving the news or the diagnosis of just needing to engage with a pediatrician at all, or needing to engage with a specialist. There's building that knowledge and building that expectation. And during the consultation, there's a lot of information to absorb, and there's a lot of different levels of information to absorb. And many families have reported wanting to be more engaged and more connected in the actual consultation experience, but they just felt it's like too much work to try and absorb the information and actively engage in the process at the same time. They often say that they're out in the car park before they realize what they actually wanted to say during the consultation. So often the after steps of the consultation and the introduction of supplementary material can be one of the most important features of the diagnosis or the diagnosis continuum experience, so that they can absorb it later or differently and in different ways. And again, this is just another couple of points around what it means to get the diagnosis from our participants' experience. And again, that word gentle comes up again and again. It's that idea of it's not something that's just dropped carelessly on the person. And this is something of a contrast. A parent being asked, why do they want the diagnosis? Even though they have lots of diagnoses, the reason parents talk about over and over again wanting a diagnosis is because it gives them a certainty and something to engage with, a foundation to engage with. And what it means to have a springboard, have a starting point in the medical relay that is 24/7 experience of cerebral palsy for the rest of that family's life and the rest of that individual's life. They shouldn't have to fight for the diagnosis. It should have been easier, and we shouldn't have to fight, as one of our parents said. Thank you.
So before we move on to Jimmy, I just want to check if anyone has any questions for Amy. We will be coming back to have a joint discussion time with Amy and both Amy and Jimmy. But I just wanted to see, first of all, if we wanted to jump on Amy's, or if anyone has any thoughts that we'd like to jump on for Amy to answer. So you can just type them in the Q&A section. But I have a question for you, Amy. With your experience on the CP Society, how early do you see families coming to you, and do they share these sort of experiences with what's the most challenging part in communication, not just about diagnosis, but communication in general?
I think, well, we have children as young as 4 weeks and 5 weeks who come to us generally from the NICUs, and they generally received some level of diagnosis experience really early on, and they've asked us to connect with them, and which we generally do. And the feedback that we receive as a community organization is that the clearer and more direct their pathway to understanding the condition, the easier it was for them. So if they were given the term cerebral palsy, it was broken down into small steps of like, what does this mean in a community setting? Like, for us, we generally work with the nuts and bolts of the situation. So like, if the baby, for example, can't use traditional toys, they want us to know, how do we source traditional toys? Or how can the big brother play with the little baby who's got CP? Like all these. So I guess that to sum it up, cerebral palsy is part of the family's lives. It doesn't have to dominate the entirety of their lives. They can still be a child. They can still be the longed for child. They just don't suddenly have to be a collection of medical problems. And I think that's how we try and ease the burden of all these things that you can Google when you Google cerebral palsy.
Thanks, Amy. I think we'll pass over to Jimmy for now, and we'll have a bigger discussion. And we'd really like to have, so there is already a question about hearing about paediatricians' thoughts on how to develop those communication skills that you've so eloquently discussed that's needed, Amy. So I think everyone, I'd like to encourage you to think about that, and in about 15, 20 minutes time, jump in when we have our joint Q&A session. But for now, over to you, Jimmy.
Thanks very much, Shan. So kia ora everyone, my name is Jimmy Chong and I'm a rehab paediatrician working through Starship Children's Health. I'd like to acknowledge the CP Clinical Network and organisers and grateful for the invitation to speak today. It's very exciting to be a part of this collaboration with groups, clinicians, people with lived experience and their whānau from across the country. And I'd also like to recognise you, the audience, for being part of this exciting initiative. So leading on from what Amy's mentioned so far, one of the main reasons why we thought it was key to share this session was to emphasise the need for effective communication of clinical information. With my background in rehabilitation medicine, my role is from a different perspective and comes further down the track, and is to provide information to help families navigate transitions in their child's development while offering advice on the outlook for the future and to do with interventions around functional needs. Underlying this is that the diagnosis is not the endpoint, it's part of an ongoing conversation. The outline of this talk is to cover areas useful in the management of a child who has cerebral palsy, focusing on definitions and terminology, then expanding this to the utility of classification systems. These can provide a language when describing a child's abilities and support needs, as well as offering additional prognostic value. This information will be familiar to many of you, and as has been highlighted earlier on today, and demonstrates the broad clinical spectrum that the diagnosis encompasses. We'll then invite Amy back, where together we can go through some approaches to discussing disability and consider how we frame our communication to be more child and family centred. For example, what is the purpose of correspondence through clinic letters? And how would we like to have first and ongoing impressions with families to be? By the end of the session, we hope that you will feel more comfortable in having a conversation with a family about cerebral palsy and recognise, critically, that we all have a role in this. A fundamental premise is that cerebral palsy describes a group of permanent disorders that influence the development of movement and posture. This occurs as a result of a non-progressive insult that has happened to the developing brain. It's an exciting time to be working in the area where medical advances, particularly in the field of genetics, are beginning to help account for the differences in phenotype that are seen. Here, depending on the situation, this can guide the view to being a clumper or a splitter. And what I mean by the term clumper is seeing how individuals have things in common, as opposed to trying to appreciate them as different conditions. Notwithstanding, the unifying principle here is that we are talking about a group of motor disorders that not only affect movement, but are often accompanied by other disturbances, medical conditions, and that can give rise to musculoskeletal problems. This figure highlights birth prevalence trends using combined data from various CP registries in Australia, showing a gradual declining rate over the past decade and one that has been sustained in the most recent iteration. And where historically the cause of cerebral palsy was thought to be related to a perinatal event or babies born prematurely, because of advances in neonatal care, as well as proportionally that babies are mainly born at term, the reality is that commonly newly diagnosed children would have received routine postnatal care and not have been identified as having risk factors at birth. Another strength of registry data is better understanding smaller groups, such as of the 6% of postnatally acquired CP, where approximately 1 in 4 have a major concurrent congenital anomaly. The other group to mention here are children who have sustained a traumatic brain injury before the age of 2 years, including non-accidental events, who can sometimes also come under this umbrella of cerebral palsy. It's recognizing more than ever there are grey areas, excuse the pun, when this translates to day-to-day clinical practice. It's become almost synonymous that cerebral palsy is related to findings of periventricular leukomalacia and predominantly white matter injury involving the descending motor tracts, while there are smaller proportions that have resulted from strokes, focal injury, or infection. However, up to a third can have appearance of abnormal imaging, a miscellaneous pattern, or complex maldevelopment. And in these instances, while the clinical examination early on might be abnormal, there may not be all the same characteristic signs seen in children with a presentation of a classic upper motor neuron lesion. There is more consistency now in the use of terminology amongst clinicians, where around 70 to 80% of individuals will demonstrate spasticity. And it can be useful to explain to families that this term relates to a specific finding related to damage that has occurred to the motor cortex. Ataxic cerebral palsy is far less common and accompanied by clumsiness, imprecision, or instability. Movements are not as smooth and may appear disorganized and jerky. Ataxia causes an interruption of muscle control in the arms and legs, resulting in reduced balance and coordination. Moving along, the presence of dystonia within the wider group of dyskinetic movement disorders is now better appreciated, and something I'll go into more detail in the coming slides, where what I tend to see in clinical practice is more of a mixed pattern with one movement disorder that is predominant. Describing movement in CP. In these situations, it can be helpful to consider this within different categories. For example, if there's increased tone or hypertonia, which is something you can feel, versus increased movement or hyperkinesia, which is a finding that is seen. Thinking also about the palsy aspect of cerebral palsy, the negative motor signs are just as significant, which include weakness, reduced selective motor control, difficulties with balance, coordination, and sensory perception. Similarly, when describing their physical assessment, spasticity is the reproducible presence of having a velocity-dependent increase in muscle tone and manifests as a catch or resistance by involuntary muscle contraction. This is due to loss of descending inhibition of the spinal reflex arc and is seen in conjunction with having abnormal limb reflexes. In contrast, dystonic movements are also involuntary, but often marked by sustained or intermittent twisting or repetitive movements, abnormal postures, or both. Importantly, dystonia can vary from second to second and is often worsened when the person is concentrating on becoming emotional. This can similarly be triggered by factors, particularly pain or discomfort, and the subtlety here is that the intention, where possible, is to identify and manage the underlying cause rather than solely focus on reducing movements. Spasticity creates persistent abnormal forces and pulls on muscles and joints, leading to an increased risk of contractures or other musculoskeletal deformity. While one of the distinguishing features of dystonia is asking the question whether muscle stiffness is absent when the child is asleep, and are they able to fully relax? Children with dystonia use lots of energy to overcome this centrally driven movement disorder and have increased muscle definition and little subcutaneous fat. It's also useful to ask if there are specific tricks that a child or parent can adopt to break a dystonic pattern. This is an opportunity now to test your existing knowledge in the area. The GMFCS Gross Motor Function Classification System in cerebral palsy is based on which clinical features? The best answer here is E, typical function across settings. There's sometimes confusion about option C, but important to point out that the system is not about capacity or optimal performance, but typical of function across different day-to-day settings. And furthermore, as Robert Palisano recently said, none of these systems are a test, an outcome measure, or a diagnostic tool, nor should they replace appropriate assessment instruments. Each simply describes a level of functioning in their respective domains. The GMFCS is based on a 5-tier ordinal scale, where there are different charts and descriptors available depending on which age the child fits into. For example, this is one for children aged 6 to 12 years. This ranges from GMFCS level 1, fully independent with ambulation, to level 5 individuals who require a manual wheelchair to get around and have limited abilities to maintain anti-gravity head and trunk postures and control of their arm and leg movements. Key characteristics include how children manage uneven terrain and stairs, how much assistance they require in terms of the use of walking aids, along with whether or not wheelchairs are used for mobility. One of the things that I find most helpful is being able to refer back to the descriptors as they help to place a child's development within various milestones according to different age bands, and especially in the 2 to 4 year age range. So this is available through the CanChild website, and I would encourage you all to have a look at it and bookmark it. The scale looks at how a person's cerebral palsy affects their abilities and in addition provides useful prognostic information in terms of longer-term motor function. These graphs are from a landmark study published by Rosenbaum that show changes in gross motor function score, the GMFM66 over time. Each of the letters corresponds to a task that the child has a 50% likelihood of being able to achieve successfully, where task A is whether a child can lift their head up, while task B is whether a child can maintain a sitting position on the mat without supports for 3 seconds. Putting this in context, it's widely appreciated that being able to sit independently at 2 years of age is a key predictor of whether or not a child will be ambulant, so equating to GMFCS level 3 or above. Similarly, what this graph also highlights is that for most children with CP, 90% of gross motor development is achieved by 5 years, while plateaus for children in GMFCS level 5 before the age of 3. Gross motor function classification scale level tends to remain stable over time, and for individuals in level 3, 4, and 5, this can reduce slightly following puberty. MACS, or the Manual Ability Classification System, is divided into 5 corresponding levels. Children in level 1 can handle most objects, in contrast to children in level 3 who require help sitting up, or in level 4 and 5 who use their hands less commonly to perform different functions. An important point to highlight is that MACS classification reflects how children are able to use both of their hands together, which is particularly relevant when considering this for individuals with hemiplegia. Supplementary to the levels for each of the systems is an identification flowchart. This is one for the Communication Function Classification System, CFCS, and helps walk you through a decision tree and poses a useful way to think about things in a clinical setting. Firstly, asking whether a person is able to consistently and effectively perform sender and receiver communication roles, and if yes, is this with unfamiliar partners, thus clearly describing levels of ability and independence. So why are multiple classification systems needed? Well, the different systems relate to various areas of functioning or systems in the body, where a person may be more severely affected in one area, but function better in others. So pictured is the tool that has been worked on and is now going to be soon to be available for download as a resource. And I think this is a really useful schematic when looking at the different systems together. And what I'd like to also do is ask you to take the time to now reflect on your practice in terms of how we can assist families better understand the diagnosis of cerebral palsy and utilize different classification systems in a clinical setting. And as we touched upon early on, in the last few minutes after these questions, we'll welcome Amy back in on discussions about framing our approach to communication of disability. So that's focused on function and participation, being ability and strength based, as opposed to just being impairment driven.
This is just an example of what Jimmy was talking about in terms of transferable skills. This is an adapted information resource from end-of-life care and complex needs planning around what kind of questions could be framed in either the conversation or your different communication modes with the children and, well, with the family and the children. So the important point to emphasize at this particular stage is that we're not asking pediatricians or the medical professional as a whole to completely revolutionize and completely make it a utopian environment. We know that there are, as Jimmy said, many competing pressures, but the idea is to make the communication, however limited it is, or however short your appointment time is, make it as respectful and responsive to the family as possible, even if you don't have the time to be as thoughtful or engaged as you may have liked to be. And it's when talking about fields like Jimmy's, where you see people slightly further down the line of their original diagnosis, it can be useful to be mindful of where they might be on their medical calendar, on the process of learning about CP. Some may have completely isolated appointments once or twice a year, whereas others may, I've seen people's medical calendars and they have a medical appointment once a week or twice a week. So there can be a lot of difference in how much of the basic information people have already absorbed. And so it can be useful for some families though to do a level of refreshing around what are the concepts you understood from our last conversation, or being a mirror to them to get a sense of what their knowledge around your particular situation is. And this can make the rest of the conversation smoother and easier getting into the next round of appointments. Because again, you want to establish that fundamental foundation of good medical communication for a lifetime of medical relays.
So during my medical training, I learned to be comfortable with using different stylistic tendencies, if you like. So in this case example, communication can often lean towards being problem or deficit focused. And while this opening and correspondence has a role in highlighting key information, what needs to be considered is how this may be confronting as well as scary for families to be able to process after they leave the clinic room. Contrast, what if we ask, how shall we speak about your child's medical condition and needs? Has any of your child's team, and remember it's not just the doctors, asked or spoken to you about the term cerebral palsy? Despite most people having come across a person living with cerebral palsy, this can bring a variety of responses and leads me to think of a recent clinical appointment where a father was accepting that their child had had a neonatal stroke, although found it difficult when receiving an invitation letter from our service to attend a cerebral palsy specific clinic. It seems like today we're already speaking to the converted, as you've already taken interest in this area. But it's also moving away from thinking that firstly, the diagnosis can only be made when there's a plateau in developmental progress. And secondary, that this creates a ceiling in terms of what potential these children have to achieve. As Amy eloquently puts it, this can be both and an and situation. You can have both a diagnosis of cerebral palsy and also achieve one's potential. How I like to think about it is that rather than having a crystal ball, we have snapshots in time that help make the future clearer. We owe it to our families to try and understand their goals and dreams, many of whom are intelligent, tremendous advocates, and will find a way. These goals are for the most part realistic and pertinent. I often tell the story of a mother of a child who has CP, GMS level 4, who was dedicated to her child being able to walk. It was later on, and with an immense pride, that she showed me a video of her child's first steps, albeit in a harness and with support. But after this, she felt fulfilled. It's not just about ticking a box and reflects a major paradigm shift towards how disability is represented. As conceptualized by the World Health Organization ICF model, which stands for the International Classification of Functioning Disability and Health, that places conditions such as cerebral palsy within a biopsychosocial context. Key to this is how we see disability as an impact on one's health rather than a consequence of it. Therefore, for a given health condition, this focuses on the effects on the individual at different levels of functioning, including activity and participation, and needing to consider this within the environment that they live in, as opposed to merely trying to reverse or compensate for deficits through our interventions. Recapping material from the CanChild group, then the F words can help understand what might be important to a child. Function is the focus on being able to do things, even if they're done differently from other people, but finding a way for an individual to do something, and if possible, on their own. Next, recognize that family know the child better than anyone else, so listen and learn from them. Fitness, finding ways to look after one's health by staying active, including exercise and other recreational activities. Friends are key for learning, getting to know ourselves better, and importantly, for building meaningful relationships with others. Fun is about discovering things and ideas to be able to accomplish this. And lastly, the future is now, exploring opportunities and looking at what is possible rather than impossible. We can then populate the ICF framework with the first 5 F words. And paraphrasing Rosenbaum, consider the connections amongst these ideas. Imagine, for example, an increase in a child's meaningful participation, which might impact on their activities and potentially lead to changes in body structure and function. The apparently backwards direction of these connections certainly challenges our traditional biomedical thinking, but is why it can make a difference.
So with that in mind, here is the central question of our talk, perhaps, or the central ideas to consider that brings together those questions Jimmy framed and the ideas that Rosenbaum set out in the efforts. This is a worked example of function and feature that I need to give credit to Charles, Hamill and Reynolds for their work. They're a New Zealand and Australasian team that placed the F words into a real concept or real design where clinicians and families are asked to place the child's aspiration onto these number systems to get a sense and to get a starting point for the discussion around goals and setting ideas for the future in a more holistic and engaged approach, looking at these different aspects of a life rather than a collection of medical problems. Cerebral palsy is a time and resource intensive condition. There's no getting away from that. You only need to look at a snapshot of the amount of medical appointments that it incorporates to really get a sense of that idea. However, that doesn't mean that there aren't many opportunities along that medical process to incorporate the function and the future into these communications and into the child's everyday life. And that's where my repeated metaphor of the relay system comes into play. We have all these points along the journey of this medical process that starts, yes, with the diagnosis, but with the diagnosis conversation, not the diagnosis as in the big scary word of cerebral palsy. It's a process. And that's where we each have a starting point along that process for the family. And just a piece of really practical advice, it can be very useful to Google cerebral palsy every now and then and read the first 1 to 5 pages, because you can guarantee that that's what the families are, a lot of families are absorbing, either directly through searching or getting advice through communication groups. So I've always found it useful to keep up to date with what people are seeing before they even come into my setting as a community worker or into Jimmy's clinic type situation. It can be a useful advantage. So just an idea around the take-home messages for our joint presentation today. First up, it's not all bad. We've received many communications about excellent diagnosis experiences and excellent medical training and engagement and respect from families. But the communication landscape and the communication expectations around the medical experiences are changing. Families are becoming, in some ways, more informed. They're gaining much more sense of what it means to live with medical complications. I know from my experience living with CP, I don't know half the things that parents know now and where they place their children on the scale. And it's about aiming for a consistency of messaging around using some of the excellent tools that Jimmy resourced. And we are aware that they need to be adapted into regional situations. And the idea is to be responsive and communicative with the family in a gentle way that demonstrates that it can be a both and scenario. You can live with a condition, including a very serious and significant condition, but you can also live a life as a child who is more than just a collection of medical problems. And the discussion around that process doesn't need to be a singular event of you have cerebral palsy and that's it. There's a whole notion of what you can do to do the after the diagnosis experience as well. It's not. And to finalize, we're laying a medical foundation that will last a lifetime, both for the individual and the families. So let's make it a really solid foundation. Thank you.